Medics.com. And then go to medicine, drop-down menu, endocrine. Okay. We're going to do pancreas and gonads today. Not your gonads, just gonads in general, because talking about your gonads is sexual harassment. Correct? Yes? Mm-hmm. So we're talking about just generic gonads. But first we're going to talk about pancreas, because you can just totally get away with that. Okay, so pancreas. Before I do this, I'm going to tell you that I'm going to post a quiz for you guys. Actually, I did just now. I posted a quiz for you guys, a long endocrine quiz. It's not going to be due until next Wednesday. Open book, collaborate, talk to each other, so you can start seeing what endocrine questions look like. Cool? Okay, so you guys know where your pancreas is, yes? Okay, first curve of the small intestine, yeah? And it has exocrine functions because it makes pancreatic amylase and pancreatic lipase and some other pancreatic enzymes that are involved in digestion, but that's not what we're talking about. So its exocrine function gets dumped into the intestine, but its endocrine function gets dumped where? Bloodstream. Bloodstream. You know that. Hormones. Bloodstream. Yes. So if you took a little chunk of pancreas, the exocrine portion would be on the outside. The endocrine portion is on the inside. It's called pancreatic islets, as in little islands, or, this is way more fun to say, islets of Langerhans, which is what they used to be called before they stopped using names for things, but it's way more fun, right, to say. So inside the pancreatic islets, notice that there's a whole bunch of blood vessels, right, because it's really vascular. And then there is alpha, beta, and delta cells. I don't know what happened to gamma, and you don't either. I think it was somebody's eyelash, and they thought it was a cell, and then they're like, no, that was just my eyelash. So alpha, beta, and delta cells are going to produce the 3 pancreatic hormones that we're going to talk about today. But you already actually know 2 of them pretty well. We just have to make sure that you really, really understand them. And then, of course, we're going to talk about diabetes. So if we get to the endocrine portion of the pancreas and the pancreatic islets, let's talk about the 2 hormones that are going to be the important ones from there. The alpha cells are going to secrete glucagon, and you need glucagon when your glucose is gone. Yes? Okay. So instead of me telling you, I want to see if you guys can help me figure out what glucagon should do based on your knowledge of negative feedback inhibition systems, based on your knowledge of glucose storage, right? Which is why we do all of that stuff before we come to the endocrine system. So some questions. What do you think the trigger is for glucagon release if you need glucagon when your glucose is gone? Low blood glucose. See how smart you are? Glucagon gets you through between meals, right? And you can feel it when it actually gets released. Like if you're super duper hungry, you don't have time to eat, dumb as a doorknob, all of a sudden you're fine. Like, oh, I'm fine. That's glucagon causing sugar to get dumped into the bloodstream. So let's just look at the mechanism that actually does that. So I agree with you that low blood glucose would be the trigger. Detected where? Pancreas, yeah. Detected pancreas. So the pancreas has a few functions in this reflex arc. You don't have to worry about which ones they are for right now. And then the pancreas is going to respond by alpha cells release glucagon. Okay, now I'm going to let you figure this part out. Where should glucagon go, target, to help in this problem? Glycogen stores. Yeah, where? Where are the primary glycogen stores? Oh, yeah. Goes to the liver. Other places as well, but the liver is the primary target. Okay. And what does the liver do? Breaks down glycogen. Yes? Where does it put it? Yep. So that increases your blood glucose. You with me? Okay. And what do you think the feedback mechanism is? What's the feedback mechanism? Not glucagon. It's not glucagon. What is it? Yeah, it's glucose itself that feeds back as the new data to the pancreas, yes? negative feedback inhibition. Do you see? Okay. So you can have it feedback to the pancreas if you want, but I always draw it this way because it's actually the new information that goes in, right? Does that make sense to you? It is going to the pancreas, but it's the new information that's going to the pancreas. Does that make sense to you guys? Okay, so question for you. What kind of feedback is that? Humoral, and why? Somebody tell us why. Why is this humoral feedback?
Because it's self.
Nope, it's not because it's itself. It's something about what's feeding back. It's a nutrient or ion doing the feedback, not a hormone, not the nervous system. Does that make sense? Got it? Okay, now, this you can memorize, but here's where the thinking comes in, right? It will also do pretty much anything that seems reasonable to increase blood glucose. So let me show you. Okay, so this is the simple one. Okay, so the simple one, that's insulin. Here's the simple one. Oh, so this is the simple one. But you can actually add a little more to it. But here's the thing. I don't want you to try to memorize this. I want you to try to see if you understand that this is consistent with glucagon's function. So, of course, we know that the major target of glucagon is going to be the liver, and it will do glycogenolysis. You guys remember that word, right? What's it going to do in the liver when you run out of stored glycogen that is consistent with its function? Gluconeogenesis. They should have done these in the other order, right? Because you would definitely do glycogenolysis before you would do gluconeogenesis. Does that make sense to you? Okay. So it would do gluconeogenesis. And then, although you don't have to memorize this, I want you to see if you understand this. Glucagon also targets adipose tissue to do lipolysis, because if I actually dump some fatty acids into the bloodstream, then other things can eat those, and I can save the glucose that was low for instance, the brain. Does that make sense? So it's really increasing circulating nutrient levels and making your nutrients last a little longer. Is that okay? Okay. So its major target is for sure the liver, but its other target is adipose tissue, and it does lipolysis. Because basically that kind of saves the glucose for the brain, because the brain gets dibs. Does that make sense? Okay, so this is what you have to memorize. That would be a logic question. Which of these is consistent with the major function of glucagon? I could say gluconeogenesis, glycogenesis. Ooh, glycogenesis? Why not? I agree with you, but why not? What would glycogenesis do to your glucose concentration? It would decrease it, right? Okay. Lipolysis, right? That would be consistent. Does that make sense? So those are logic questions. Those are higher level critical thinking questions. There will always be some of them on tests. And as you get better critical thinkers, there will be more of them on tests. Never enough to completely tank you. But by the time we get to the end of the semester, if you can't do those, you shouldn't make an A. Right? You really shouldn't. You're a B student if you can't do high-level critical thinking. Yeah? So I'm trying to get you guys to the point that you all can do high-level critical thinking. Okay, so that is glucagon. It's humoral feedback. Everybody good with glucagon? After you've done with glucagon, then insulin's pretty damn easy. Yes? Because insulin's just like its partner. Good? Okay? So, and we already kind of know about insulin. What's insulin's major function? It brings down blood glucose, right? Okay. And primarily by putting it where? Inside the cells. Okay, so let's build that. Can you guys help me? Since you did this one, we did this one together. Help me build this one. So what is the trigger for insulin release? Yeah, high blood glucose. Yes? So like after a meal. Okay. And high blood glucose is going to be detected where? Pancreas as well. Good. And the pancreas is going to respond by what kind of cells? They're the beta cells. Release insulin. Everybody okay with that? Okay. And insulin is going to go where? What do you think? What? True. Yes.
It's going to go to the blood glucose to help.
It's going to go, but where are insulin's target cells? What do you think? Almost every cell in the body. Yeah? Almost every cell in the body has insulin receptors. Not every one, but almost every one in the body. Yeah? So it goes almost all cells. And what does it make them do? Open. Do you remember how you get glucose inside a cell down its concentration gradient? Increase. What's that transport mechanism called? It is. Glucose facilitated diffusion. So these would be glucose carriers that are activated by what? By insulin. Yes? Okay. So now the sugar goes from the extracellular fluid to the intracellular fluid for use in, what do you use it in there for? Give me the freaking thank you. Cellular respiration. Cellular respiration. Okay. Now, increased glucose facilitated diffusion in cells. What does that do to your blood glucose levels? Yeah. And what do you think the feedback mechanism is? It's glucose, yeah? Glucose feeds back as the new data to the pancreas, negative feedback inhibition. What kind of feedback is that? Humoral. Yeah? It's humoral negative feedback, right? And I know that you know, but some of you haven't grasped it yet, so somebody else explain. Why is this humoral? Ions are nutrients feeding back as humoral. Hormones feeding back as hormones. Nervous system stimulation changes as neural. Good? Everybody good? Okay. So now, of course, this is the simple, and this is the major function. You definitely need to memorize this for sure. But now we can look at what is also consistent with insulin doing. Does that make sense to you guys? Okay. All right. So what is also consistent with insulin's function are some things. So here's the simple one, right? High blood glucose, beta cells, insulin, cells throughout the body, increased glucose uptake, glucose goes down. Negative feedback. But, of course, you can do things that are consistent with this goal, yes? And so even though you do not have to memorize these, could you think through them? Okay, so this is the one that we memorized. High blood glucose, beta cells, insulin. Most tissues increase glucose uptake, decrease glucose. Good? Okay. But does it make sense to you that this will also, for instance, be the trigger in liver and muscle for glycogen storage, which is glycogenesis, right? And if there was any glycogenolysis or gluconeogenesis going on, you would stop those. Yes? So do you see that you can figure that out? Do you see why I taught you all those glyco-gluco words a long time ago when we weren't doing anything hard? Because you don't want to learn them now, but hopefully you already know them, right? That make sense? Okay. So, everybody good with that? Yeah? Okay. All right, so I want you to be able to think through those kinds of things for high level. Maybe 10% of your test is that kind of level of thinking. Okay, anybody have questions?
Would it be accurate to say that like there's an alpha and a beta like response with the pancreas because of the alpha and the beta cells? Mm-hmm. So that an accurate statement that you could.
Yeah, I mean there's alpha cells responding. Alpha cells respond to low blood glucose. Beta cells respond to high blood glucose. Yeah, they're just two different cells that are activated by two different glucose levels. Good? Okay, so and then the last thing, and this one you don't have to learn in much detail, is I'm just going to tell you about somatostatin, and then we'll go back and do the diabetes. And we're going to take some time to talk about diabetes. So somatostatin is released by the delta cells, right? Yeah, delta cells release somatostatin. Also comes from the pancreas, but here I'm just going to give you a quick version of somatostatin. All somatostatin really does is makes the pancreas really sensitive to these feedback loops. In the absence of somatostatin, it's kind of hard to turn off the feedback loop for either one of them, okay? But I also want to acknowledge that you've met somatostatin before in a different context, right? Do you remember meeting somatostatin before? Where did it come from? Came from where? I didn't hear you. Yeah, right? Somatostatin, anybody remember? Okay. So it's a hypothalamus hormone. That doesn't have anything to do with this. When your body knows how to make something, it can make it for multiple different purposes. So that was just a hypothalamus to anterior pituitary, not the same function at all as pancreatic somatostatin, okay? So don't get confused. Pancreatic somatostatin simply makes the pancreas really sensitive to the feedback, okay? Cool? And that's all you really need to know about it. You don't have to draw a feedback loop for it or anything. All right, so now is the time for us to, of course, talk about diabetes. And even though this is all that's written in your notes about diabetes, you're going to be really responsible for understanding diabetes. And why? Well, because I don't care what area of human health you're going into, you are going to be dealing with diabetic patients. Whether you are a physical therapist, whether you're a pharmacist, whether you're a nurse, whether you are a rad tech, whether you do just damn near anything, you are going to be dealing with diabetic patients. And so diabetes ends up impacting all of your body systems, because what happens with diabetes is it causes problems with cells being able to take in normal amounts of glucose. And how many of your cells need glucose? All of them, right? And if they cannot do that, right, what's going to happen is if they don't have glucose, they can't do adequate levels of cellular respiration. And then they can't maintain homeostasis because they don't have any ATP. If they can't maintain homeostasis, then very often they die. That's an especially big deal if you run into any cell that is amitotic in adulthood. Meaning if you die, you're dead, right? So really important cells that are amitotic in adulthood is the vast majority of your neurons are amitotic. So do not fool yourself about the impacts of diabetes on the nervous system. Diabetic neuropathy can make you lose limbs, for instance. Also, don't fool yourself about the impact of diabetes on cardiac muscle, which is also amitotic. Most people with untreated or improperly treated diabetes will have heart disease and are at higher predisposition to heart attacks. And then because of all the sugar that's in your system, it's really hard on your kidneys. And so most kidney dialysis patients are diabetics, yeah? So you're gonna run into this in just everywhere. So I want us to get the opportunity to ask questions and kind of understand it as we go through today. So we're gonna go through the two major types of diabetes today. And they both are going to have a similar suite of symptoms, but for a different cause. So first one is type 1 diabetes mellitus. First off, let's acknowledge that we've seen another disorder that was a diabetes, right? We saw diabetes insipidus. Diabetes means pee a lot. Insipid means bland. So pee a lot, bland pee. Mel means sweet. Diabetes mellitus, pee a lot, sweet pee. Okay, we'll see why it's sweet in just a second. That makes sense? And so both forms of diabetes mellitus are going to, when not treated properly, end up with lots of sugar in the urine. Okay, all right, so the first one, T1DM, type 1 diabetes mellitus, also called IDDM, which is insulin-dependent diabetes mellitus. This one is a combination, as far as we know right now, of generally a genetic predisposition, perhaps, and then an autoimmune disease attacking your pancreas. Okay? We used to call it juvenile diabetes because, historically speaking, it has manifested much earlier than type 2 diabetes, but in the United States, we have people getting type 2 diabetes as early as 7 years old. So now they no longer refer to them as juvenile and adult onset diabetes. And we'll have an interesting conversation about type 2 diabetes in just a second. But this one, type 1 diabetes mellitus, usually people either, you don't usually have it from infancy, but it usually manifests by 3 or 4 in some kids. But sometimes you can get it as an adult because you just had an autoimmune thing happen. And if you have a family history, you know that you've probably got more of a genetic predisposition. So you don't inherit it, but you inherit the same set of genetics, right? Okay, so I want to talk about that one.
So it attacks the pancreas.
What?
It attacks the pancreas.
Your immune system,
Yeah.
for whatever reason, attacks your pancreas. Yeah. Okay, so this is the issue that we are having right here. So if your immune system attacks your pancreas and it kills off the beta cells that release insulin, let's predict what that's going to do to your insulin level and then to your sugar level over time, okay? So what's going to happen to your insulin? It's going to decrease really dramatically. What's going to happen to your blood glucose? It's going to skyrocket. But what is happening inside your cells? They're starving, right? They're swimming in food, and they're starving.
They're literally, it's in front of them and they can't eat
They cannot get it in, right? Because the facilitated diffusion of glucose into most cells is triggered by insulin. So you've got cells that are just swimming in food. They can see it everywhere, but they can't take it in, okay? And so this is severely problematic. And of course, again, the symptoms that you get, you can, for instance, if it happens with your nervous system, your nervous system and your immune system and your cardiovascular system and all of those are starving. And you get symptoms like, of course, really high blood sugar, but that doesn't sound like your cells are starving. But the cell starving thing is the issue because diabetic neuropathy, so for instance, if I step on a nail, right, it hurts, I feel it, I take care of it, put some Neosporin on it, whine about it, right, take really good care of it because I know it occurred. But if I have diabetic neuropathy and my nervous system is no longer sending signals, I step on a nail, I didn't know that it occurred because my nervous system isn't sending signals, right? And also my immune system is depressed, so it's not healing very well. And then third, my cardiovascular system isn't functioning very properly, so I'm not even getting very good blood flow to the area. So what can happen in that situation is a minor wound ends up with a long-term healing process. You can even end up with diabetic gangrene and amputations, yes, that occur not uncommonly with improperly treated type 1 or type 2 diabetes. Does that make sense to you guys?
it. Is that why
Okay.
most diabetic patients, when they get amputated, it's like their foot or their toes first?
Yeah, it's just because the neuropathy, if you've got longer nerves, right, it's more likelihood that they are going to, have sensory problems with transmitting the input. Does that make sense? And Larry H. Miller, before he died, I don't know if you guys know the local dude, Larry H. Miller, he had diabetic neuropathy and ended up losing, I think, 2 limbs in the process of his diabetes. So,
He ended up going blind too, didn't he?
I don't know, but retinopathy is really common too with diabetes. Diabetic retinopathy, because your retinas actually use boatloads of glucose. Diabetic retinopathy will manifest with blindness, heart problems. In addition, people with untreated or improperly treated diabetes, they have so much sugar in their system that the combination of sugar and any fats that they eat gives them a high predisposition to arteriosclerosis and atherosclerosis, which leads to hypertension, which leads to heart disease, which can lead to strokes. It's just everything. It's like the worst set of symptoms that you could possibly imagine because you're affecting cellular respiration, right? And every single cell, of course, needs to do that. So type 1 diabetes mellitus is here. That's where the problem occurs. And you're already predicted the level of sugar and the level of insulin that would occur with that. If it's diagnosed, then how do you treat it? Yeah, you treat it with insulin, but of course insulin's a peptide, so can I take an insulin pill? I cannot take an insulin pill. The primary delivery mechanism, and they're trying some new things, they've tried some nasal sprays and stuff, but the primary delivery mechanism has to bypass your digestive system, right? So it's injection. It's the primary thing. But it's not just the same level all the time. What you're trying to do is to mimic this outside of your body. It's really difficult to do because this is done real time and it's checked constantly. But with a diabetic, what you're going to have to do is intermittently, you are going to, the classic way is just to check your blood glucose levels, right? And whatever it is, tells you exactly how much insulin you should put. But there's human error involved in both of those. And of course, it's not real time, right? So with a diabetic, you're going to get more booms and crashes of sugar than you are with somebody who's not diabetic, right? Even if they're really trying hard to treat it, because they're literally not doing it every second of the day, right? And now, of course, there are insulin pumps, and insulin pumps make it a little better because there's 2 forms that I know of. There might be a 3rd form by now. One of them, I prick my finger, check my blood glucose level, input that number into my pump, and it's got 1 port that it actually just completely circumvents the human error with the right amount of insulin to inject, right? And then the other one actually has 2 ports in which it checks, calculates, and then injects, right? Okay, but not everybody's going to get an insulin pump because we are a for-profit medical system in the United States. And if you were in Canada and you had diabetes and you were a good candidate, you would get an insulin pump. And here, you need to have very good insurance. And then in addition, they also need to make sure that you're a really good candidate for something that costs that much. So the last time I checked, I have a friend with an insulin pump. She had to regulate her blood glucose and insulin for 2 years straight in order to qualify for her pump.
It's
Yeah.
insane.
What?
My uncle had to do the same thing.
Yeah, 2 years. I don't know if it's still 2 years, but 2 years. And so you have to, doing this is without the pump, it's a full-time job. It's just like you constantly have to assess what you're eating and what the likely impact on your blood glucose is. And then in addition, your activity levels really impact your blood glucose as well. When you start becoming physically active, your blood glucose immediately goes up because of some other hormones we'll learn about in just a little bit, but then it really drops, right? So for instance, my son's got a classmate who, my son's in 8th grade now, but he's had this same classmate since he was in 3rd grade when he was diagnosed. And every time Cohen goes to recess since 3rd grade, he has to give himself an insulin injection, right, before he goes to recess because his blood glucose level is about to change. He has to do the same thing before and after meals. And so it's relatively complicated to make sure that you're actually doing this well. So the pump, if you can qualify for a pump, tends to make their booms and crashes less frequent, which of course means that they're less likely to have cumulative damage on their cells, right? But again, not everybody's going to qualify for a pump. If you're, for instance, drinking a lot, they're not going to give you an insulin pump. If you're obese, they're probably not going to give you an insulin pump. If you're inactive, they're probably not going to give you an insulin pump. So, type 1 diabetes mellitus. Apparently, one of my students told me that there's like a new little thing that's like not a pump. It's a glucose
But it's
meter.
continuous.
A continuous glucose meter, like a little patch, lasts a couple weeks.
It's a sensor. You can app on your phone.
Yeah, an app on your phone and stick the sensor
They're
on there.
so expensive. I work in pharmacy. So
Oh, you do? Okay.
Some insurances are really great, but most aren't covering it. Yeah.
How much do they cost?
So it doesn't regulate the glucose level. I mean,
No.
sorry, it doesn't regulate the
It's
insulin
like
level.
a test strip.
Yeah,
You don't poke yourself. You just check it.
Right. And it's more continuous.
You put your phone up to it.
So in the US, it sticks on,
Mhm.
and if it falls off, sorry about you. Like my coworker, 2 of my coworkers have type 1 diabetes, and one of them has a pump and the other one has that.
Mhm.
In the US, it just sticks on. She lost it, and you can't stick it back on.
Yeah.
And then in other countries, though, it's like injected into your skin. Like there's needles
Interesting.
on one side of it, so then it can stay for a really long time, and you don't have to buy a new one all the time.
Ah, interesting.
So
But they
the
won't
sensor
do it in the
here
US.
lasts for 2 weeks. So you
That's what I
can
heard
get it
last
for
time,
2
it'll
weeks.
last for 2 weeks. And it hooks up to an app on your phone, and then you
Yeah.
just decide the insulin injection based on the app,
Yeah.
which is better, and that's cheaper than the pump, even though how expensive is it? Do you have any idea?
I haven't seen the actual cash price because most of my patients, it's covered.
Covered with insurance? Yeah. I want to know how much it costs. Try to find out, okay? I want to know how much it costs. Okay, so that's type 1 diabetes. Autoimmune genetic component, right? So, for instance, probably all of us know somebody with type 1 diabetes. One of my friends has type 1 diabetes. He has 3 little boys. 2 of them have type 1 diabetes, but they didn't inherit it from him. They just inherited this genetic predisposition, and then it manifested by the time they were 5 and 7. Go ahead.
I just looked it up. It's $6,000.
This thing?
Yeah, it says without insurance, new insulin pump costs $6,000.
Oh, pump. That's pump.
Oh, not the pump.
Pump. Patch. I don't know what it's called. What's it called?
I-
Sensor.
It's
Somebody look it up.
called,
She'll figure.
my brother's girlfriend has both.
Interesting. Oh yeah, I want to know. So collective knowledge, right?
People are gonna think that we're
okay.
like, just asking us random
I
questions
know,
in the
I've
middle
never
of the
texted
day.
her before in my life.
Hey, what's this?
You should also ask her out
This
for
is
like,
Tori, by the way.
you know,
Freestyle-
your brother's sister, your girl,
Freestyle
your
Libre
boyfriend's
is the
sister.
name of it.
What?
Freestyle Libre.
Yeah, this
Freestyle
is
Libre.
Libre sensor.
Gee.
Okay, now we're about to talk about type 2 diabetes, and tell me when you find out. Go ahead.
I have a question. So why is it such a big problem when their glucose drops? Like, do they not go into like glycogen storage?
They don't tend to have very good storage because they have really poor insulin. So this goes back to this, right? So let's go here for just a second and tell me why somebody with diabetes would probably have not very good glycogen stores. Do you see? Because it's insulin secretion that causes glycogenesis. Yes?
So reversing it, like if it was low insulin secretion.
Well, they just don't have any glycogen stores in their liver in general because their booms and crashes don't have much to mediate them at all. Go ahead, Clint.
The continuous glucose monitor is 700 transmitter, and then the sensors are 50 to 75.
50 to
Yeah,
700.
it's
Okay.
the
Go ahead.
meters that are expensive. I actually do have a question.
Okay.
I work at the U hospital. Most of my patients have major type 1 diabetes, tend to lose limbs. Is
Yeah,
that
that's
because of
diabetic
the
neuropathy. No, it's because of what we just talked about. Diabetic neuropathy and depression of the immune system, meaning that you have poor circulation, which of course is a problem, but then if there's any injury, there's also no healing. So the combination of neuropathy, which says I don't feel it, the depressed immune system, which says I don't heal it, and the slowed down cardiovascular system, which says I don't feed it. And then you can lose limbs. Go ahead.
Does the glucose play into that as well? Because I've heard that when people are going to get surgery and they have high A1Cs or whatever, high glucose levels, they also tend to feel slower. Is that the glucose, or is that because
I think it's because of the diabetes. I don't think it's because of directly the glucose. It's just an indication of the diabetes. I don't know that for sure, though. But we do have to move on. So go and then go, and then we're moving. Okay, go ahead.
Really quick, she just texted back. So she says I have both the pump and the sensor without insurance. My pump is about $800, and the sensor is $600, and I have to replace my sensor every 3 days.
Oh, God.
But she has like really good insurance. All her diabetes
Care is taken care of. Don't lose your job.
She's
Okay, so we're moving on. These are fantastic questions. I really appreciate them, but you are also going to have a test in your near future, and we're going to do this. Okay. Type 2 diabetes, T2DM, also called NIDDM, non-insulin dependent diabetes mellitus. Okay, used to be called adult onset diabetes. We don't get to call it that anymore because we're in America, and somebody said that people get it as adults, and we said, pew pew, freedom. We're going to give it to our kids at 7. So having either form of diabetes, the diagnosis before age 12 reduces your life expectancy by 17 years.
Wow.
Yes. There's so much that can go wrong there. So I want to tell you the story of type 2 diabetes and make sure that you actually understand it. Oh, by the way, type 1 diabetes, classified as hypersecretion or hyposecretion? Hyposecretion, exactly, right? Of which hormone? Insulin. Good. Okay, now compare that to type 2 diabetes. Type 2 diabetes has all the same symptoms associated with it, but also usually obesity and the things that come with obesity, right? Including high cholesterol, because you don't usually get obese by eating a whole bunch of vegetables, do you? No? Okay. So I want to take you to Alabama. You ready? Okay. Because if you want to see some diabetes, you can go to Alabama. Okay. I'm from the South. I can make fun of these people because they are my people. It's fine. Okay, so if you want to see some type 2 diabetes, you need somebody who is relatively inactive because using your skeletal muscles is a non-insulin dependent way to drop your blood glucose, right? Okay, and people with diabetes end up figuring out that it's much easier to regulate if you're actually exercising regularly. Okay, so, and we'll talk about that when we get to skeletal muscle, but I just want to tell you that exercise actually helps to regulate your blood glucose without insulin. I mean, you still need insulin, but it helps. So low levels of activity in combination with high levels of carbohydrates, especially in combination with fats, interestingly, but not for a reason that's good to explain right now. So high levels of carbs. So basically what you have is Bubba, right? And you know there's a whole bunch there, right? In Alabama, Bubbas and Juniors. We can all laugh. Has anybody been to Alabama but me? Okay, Bubbas and Juniors. Yes. Oh, in South Carolina, yes. Okay, so it's just true. Drinking lots of sodas, probably also lots of beers, very, very low levels of activity, as low as you can get, like the Walmart things at age 16, right? And so a lot of obesity going on there. It's like seriously a public health problem. So what you're going to have in situations like that is, and Alabama is the fattest state in the country. It's also the least educated state in the country. So what you're going to have in that is, if you go that route for decades, it's not, you can get away with it for a day, you can get away with it for weeks, you can get away with it probably for all 4 years of college, as people do, right? But you cannot get away with it forever. So what happens is you have taking in lots and lots of carbohydrates, right? And then your insulin goes up to try to take care of it, but then you drink 3 more beers and 2 more Cokes, right? And you do that over and over and over and over again for decades, right? And then what happens is eventually your body has tried so hard to regulate your blood glucose with your insulin, and then it says, screw it, this is not working, and it goes to plan B. And plan B is to do what to your insulin receptors? Downregulate, decrease the number and sensitivity of your insulin receptors, right? So now that becomes severely problematic, because now in between meals or when you're sleeping or any other time that you're not taking in tons of carbohydrates causing you to release tons of insulin, is a normal level of insulin going to cause glucose uptake in your cells? No. So your cells are going to starve and then boom, and then crash with sugars.
Because they're so
right?
used to having a high demand of sugar.
They're not used to it. It's downregulation. It's downregulation. You are not going to respond to normal levels of insulin. You only respond to high levels of insulin, but you cannot have high levels of insulin constantly, right? You just don't. So the cells end up having booms and crashes and all of the cumulative damage that occurs. But in addition to that, you generally have obesity. Now, not everybody with type 2 diabetes is obese, but most of them are, okay? Because, of course, you could have a really fast metabolism and have all of these problems. So type 2 diabetes mellitus has all of the same problems, plus an increased likelihood of heart disease, because there's usually cholesterol involved in the diet and all that kind of stuff. And the important thing to understand is that it's completely preventable for almost all of us, type 2 diabetes. And it is increasing by leaps and bounds in this country, and we're even exporting it to other countries. And nobody used to get type 2 diabetes until their 30s at the very earliest. But now, of course, kids are getting it as young as 7. And I'm generally not a blamey person, but let's all be honest for a second. If your child gets type 2 diabetes at age 7, who gave it to him? Yeah, totally. And they're like, oh, but they like soda. Duh.
Who doesn't?
They want candy. Yeah, right? Some of us like crack, but we also want a job, and we decide not to, right? Go ahead.
So gestational diabetes, is it because you are on the verge of having type 2 diabetes?
No, it's actually got to do with the levels of cortisol during pregnancy. It's a whole different thing. Yeah, it's different. And it usually just goes away, too. So, yeah. It does make it more likely to develop type 2, but usually it's acute. It also, though, is usually, you're more likely to get it a second time if you have another pregnancy. And if you've had it twice, you're more likely to get type 2 diabetes later. So it does increase the likelihood, simply because whenever you have it, it's doing downregulation. And then your body goes, oh, let's do downregulation. That'll be fun. And then you end up with type 2 diabetes, even though you've been otherwise healthy. So with this, how do you treat it? So Bubba goes to the doctor, and the doctor says, your insulin levels are low and your sugar is high, and you are either borderline diabetic or you're actually diabetic. And what does the doctor first tell Bubba to do? Diet and exercise. But Bubba is an American. Freedom. Pew, pew. What does he do?
Nothing.
Nothing. At all. Comes back later, right? I mean, do you not have a Bubba in your family? You do, don't you? You do. Okay, we all do. You might not claim them, but we all do. Okay, so tells you diet and exercise, but of course Bubba's not going to do that. So what do they do next? Metformin, which it simply tries to artificially regulate your blood sugar. It is nowhere near as effective as diet and exercise. If you use it in combination with diet and exercise, sometimes you can even reverse the early stages of type 2 diabetes or the pre-diabetic situation. But it cannot do this as effectively as your body actually does. So it is not a cure, it is a treatment, but you actually could have a cure in the early stages of type 2 diabetes. They keep doing exactly what they were going to do. Right. Yeah, and the unfortunate thing, and can we all just agree that it's kind of lame, that almost always the freaking answer is diet and exercise? It's really stupid. I hate it. I want another answer. I would like to talk to the management, please. But it is diet and exercise. I mean, not if you've got schizophrenia or something, but half of like the metabolic disorders and stuff. I mean, it does help though. I mean, diet and exercise does help in that situation. You can make it worse. But anyway, so what is this? So this disorder is classified as hypo or hyper responsiveness. It's not a secretion problem when you get it, but it's caused by a secretion problem. So it's what, hypo or hyper responsiveness? Hypo responsiveness because of chronic hypersecretion. Yes? So that's the progression of diabetes. Chronic hypersecretion causing hyporesponsiveness. Now, the worst type of type 2 diabetes you can get is later on when Bubba just insists on doing damn near nothing and won't even take his metformin, is that he ends up, his pancreas just quits on him. And then he is an insulin-dependent, insulin-resistant diabetic who needs insulin injections, but do normal levels of insulin work? No, they do not. And generally speaking, in a situation like that, he's probably headed for kidney dialysis. Probably really, really trashing his kidneys in that situation. Okay, so, and then we already talked about the delta cells that produce somatostatin. So I hope you hear in the amount of time we spent that I do expect you to be able to talk about diabetes. If you have a textbook, it's on page 617. If you don't have a textbook, find a reputable source to make sure that you understand the physiology of diabetes. And do not go to Joe Blow's homepage that tells you if you buy this crystal, it'll cure your diabetes. Make sure it has a .edu at the end, right? And there's nothing for sale on the page, right? That's what you need if you want a reputable source. So there's lots of open source physiology textbooks out there if you didn't buy one. Okay, so.
So it's caused by a hyper secretion of the insulin. No.
What? Go ahead. You can answer.
So it's your glucose is so high that your body is sending tons and tons of insulin, and eventually it just gets like lowers the
Bubba.
insulin.
Then hypersecretion, then hyporesponsiveness. Right? Okay. I mean, it could very easily be Peggy. It doesn't have to be Bubba. We're not picking on males because women get it too. Okay. But 7-year-olds are getting it, and that was a record. That was just a record that was like last year or 2 years ago. Before that, it was 12. 12 was the earliest with type 2 diabetes. Okay. The other thing is, let me go ahead and tell you that there is a genetic predisposition that you have to deal with type 2 diabetes. If it runs in your family, you need to be more careful about it. And people of African descent have a higher predisposition for type 2 diabetes than a lot of people of other descents. Does that make sense? And so you just need to be more careful. It's not a sentence. For instance, I have a predisposition to smoking-related cancer, strokes related to smoking, and heart disease related to smoking because both my parents smoked. They got all that crap. They died. But guess how I manage it? I just don't smoke. Exactly. Exactly. So it's a predisposition. It's not a sentence. Okay, so now let's talk about gonads. Not yours, though. Just people's. Or we can talk about rat gonads if it makes you more comfortable. I don't care. Okay, so let's talk about some nads, man. And so we will actually finish the sort of the feedback loop that we started before. So I want to start with the testes. I don't have to tell you where they are, do I? No?
I would hope not.
No? Okay. So, well, I'm going to anyway. There they are, right there. Okay, so the testes are going to secrete a group of hormones called androgens. Andro means male, so the androgens collectively are these guys right here. DHEA, androstenedione, testosterone, and dihydrotestosterone. They're all similar, but they have different affinities for receptors in different places. Everybody cool? And some of them have a much higher affinity for receptors. So we've looked at those before. So collectively, we're going to call those androgens, and we're going to say, what do androgens do? Well, androgens in an infant Fetus, fetal development, 6-7 weeks. No, that's still fetus. I think it's embryo before 8 weeks, actually. So embryo, embryo before 8 weeks. In an embryo, what they do is they put together the primary sex characteristics. And the primary sex characteristics is, oh, this could be a clitoris, but I'm going to make it into a penis, right? This could be ovaries, but I'm going to make them into testes. So they put together the primary sex characteristics. Talk about that in a second. I want to talk about what they do once you hit puberty, right? Because from fetal development until puberty, males hardly have any appreciable amount of testosterone or any of the androgens. But then when puberty hits, you're of course going to start the development of what we call the secondary sex characteristics. And that's all the changes that happen physically and mentally when a male hits puberty. So for instance, an increase in muscle mass, an increase in bone mass, height, axillary hair, pubic hair, thickening of the vocal cords, thickening of the larynx, all of that stuff, facial hair, and then feeds back to his brain, sex drive. Yes? And also aggression. Testosterone does increase aggression as well. So testosterone is also necessary for spermatogenesis. Because testosterone tends to make you do protein synthesis, it's considered an anabolic steroid. Anabolic, does that make sense? Anabolism is building things, okay? In a little while, we're going to run into some catabolic steroids, but this was an anabolic steroid. So I want to talk about it. So you guys know the story that ends with testosterone. You might not know all the details, but you know the beginning, right? If I am going to secrete testosterone, what organ starts it? Hypothalamus, exactly. Okay. And the hypothalamus secretes what relevant hormone? Yeah, GnRH, and she was going to say the long version. What was it? Gonadotropin releasing hormone. Okay. And gonadotropin releasing hormone, of course, goes where? Anterior pituitary. And the anterior pituitary releases 2 hormones, but we're going to concentrate on the side that gets us testosterone first. Okay. So it releases luteinizing hormone, LH, and LH, what?
It's an FSH.
No, not that one.
No.
LH goes to the gonads. And specifically, I don't know if you guys learned this in anatomy, but the seminiferous tubules are the things that make sperm. But the cells between them are called the theca cells or interstitial cells. Those are the ones that make testosterone. Okay, so it's specific cells in the gonads. And then the gonads respond by increasing androgens, including testosterone. Okay, so what do you think the feedback mechanism is to keep this dude from being in a roid rage? Yeah. The androgens or testosterone feedback to where? Why? Why can they? Yeah, lipid soluble, exactly. And they also feed back to the anterior pituitary just to make it more efficient. Cool. And so with a normal adult male, what it's going to do is keep your testosterone level, within homeostatic levels. So it's not bonkers and it's not 0, right? Okay, everybody cool with that? Okay, but there is, of course, more to it because that's not all the gonads do. The gonads also do spermatogenesis. So the spermatogenesis story starts the same way, right? But then the anterior pituitary secretes FSH, which is follicle stimulating hormone. And FSH goes to the gonads as well. But it goes to the seminiferous tubules. And the seminiferous tubules, when they receive this, and one other thing, they actually will start to go through meiosis, right? And make sperm. Yeah? So gonads, spermatogenesis. But only if you will only do spermatogenesis if you also have androgens. So these are necessary first. Good? Okay, so what's the feedback that says we have plenty of sperm? Do they swim through your bloodstream all the way back to your hypothalamus? Nobody consented to that. No, they do not. And that's probably just as disturbing for the dudes as it is for the women. I was so disturbed, I have to tell you, when I discovered that the fallopian tubes were open and sperm just swims around in your freaking peritoneal cavity. I was like, ask. Can we not get some permission going on in here? I would like to be asked about such things. So that's not what happens. Whenever spermatogenesis goes on, you also make a hormone called inhibin, but it's an IN, so where's it going to feed back? Can't go to the hypothalamus. Where's it going to feed back? It's going to feed back to the anterior pituitary, and it's just going to cut off production of FSH. Good?
So it's the inhibin that goes.
Mm-hmm.
there.
Inhibin, not sperm. Sperm stays in there.
Well, that, you know, just making sure.
I mean, did you? People don't know a damn thing about the reproductive system in my experience. Go ahead.
So the gonads also make the inhibin at the same
Yep.
time.
Gonads do make it. No, they make inhibin when you do spermatogenesis.
Oh.
Yeah. So every time you do spermatogenesis, they make inhibin. And then after a male ejaculates, then he has very little sperm and no inhibin, right? And then he makes more sperm, right? And so this goes on a lot in males. Females generally ovulate 1 or in a really, really intense month 2 eggs per cycle. Males have 350 to 500 million sperm per ejaculate. What the what? Yeah. My ex-husband said that's why he needed naps, and I didn't. And although it was funny, we were also not married. But that's not the reason. I thought it was pretty damn funny. Okay. Okay. He's like, what'd you do this month? 1 egg? I'm like, screw you, man. I mean, not screw you. Okay. Okay. All right. So let's talk about people abusing anabolic steroids and what happens here. Specifically males. We can talk about females too. And then we'll also talk about this one hormone called MIH. Huh?
Because females produce testosterone
Mhm.
too, with different levels. Is that also from FSH? Or
No,
is that
it's not. You're going to have to hold on to that question because it comes from your adrenal cortex primarily. Okay? But we won't get to that one this time. We'll get to it next time. Okay. I'm going to tell you about MIH in just a second, but first let's break this. What do we want his name to be? I think Sven. Let's call him Sven. Sven decides that Sven wants to be super duper buff. Sven does not have a testosterone problem. He's secreting normal levels of testosterone. He's just a dude. He's doing dude stuff. But Sven decides he wants to be really, really super buff. And so what Sven does is Sven decides to take in anabolic steroids in higher than homeostatic amounts to cause muscle mass building, right? So I want to predict what's going to happen to Sven's gonads over time. We know what's going to happen to his muscles, right? We've seen that happen. So what's going to happen to Sven when he over and over again takes anabolic steroids? So let's first figure out why all of this is going to happen. When you take in a whole bunch of this, look at the negative feedback that it's going to do. What's it going to do? It's going to decrease your production of real GnRH, which will decrease your production of LH, yes? Which will decrease the gonads making real androgens, right? And if you don't make real androgens, you actually don't do spermatogenesis. So if Sven isn't very, very careful, what's going to happen to the size of Sven's nads?
Peanut.
Shrink up to the size of English peas. You're going to be super duper buff. Probably super hot, but not able to do a damn thing about it. Let's be honest, right? Okay. You got to be careful what you wish for, Sven. Yes, it'll shrink up your gonads. Eventually, this can become irreversible. We never know how long it's going to take in an individual for that to occur. But then you also get all of the symptoms of high levels of testosterone. So Sven's probably going to be a turd.
Aggressive.
And he's going to have some zits, right? Going to be super duper sweaty. Yeah? Little old English pea testicles, right? And you can break this permanently. And in addition, just to add insult to injury, high levels of androgens, if Sven doesn't know his physiology and he doesn't know that he's supposed to take estrogen blockers, they'll get converted into estrogens and he'll get some breasts on top of his pecs. He will. Gynecomastia, he'll get it on top of his pecs. So Sven should have taken physiology. Pretty sure that most people who do that have not had a physiology class, right? Otherwise they would say, I don't think so.
What happens in John Tucker Must Die, that chick flick.
I haven't seen it.
It's
Oh, it's so funny.
Okay, well, let me tell you a little bit other stuff. Ready? Ready? Okay, so I want to tell you, and I'm not going to make you draw this feedback mechanism, but I do want you to try to understand it. You ready? Okay, so I want to tell you about this hormone. I teach it in anatomy, so my former anatomy students probably already know a little bit about this, but there aren't very many of you. How many of you had me for anatomy? One, Leslie? Okay. Okay, so I talk about this in anatomy too because I think it's really interesting. So this is involved, this is produced from the gonads, the testes specifically, but only during embryonic/fetal development, and it's called MIH or MIS. It's Mullerian inhibiting hormone. So just stick with me and let me tell you this story because it's kind of complicated, but then there will be a cool disorder at the end of it. You ready? Okay. How do you get to be an anatomic sex at all? Because you didn't start out with one, right? You started out as a zygote. You didn't have any anatomic sex. You didn't have any hormonal sex. You did have a chromosomal sex, right? Okay, so here's what's going to happen. XY is males. Everybody has an X chromosome or two, right? So what's really different is the presence of the Y chromosome, okay? What's really different as far as sex differentiation is the Y chromosome has a gene on it that, of course, an XX person would not have, right? And so this gene is called SRY. What SRY will do is activate this hormone called MIH or MIS. And what it does, it's Mullerian inhibiting hormone. All of us started out with two sets of internal ductwork, not quack, but the other kind of work, okay? And we started out with the internal ductwork that could become fallopian tubes in a uterus, yes? And then we started out with the internal ductwork that could also become the vas deferens and the seminal vesicles and all that kind of stuff, right? And you have both of them in the initial stages. The process of becoming a male, you have to disintegrate one of them, the Mullerian ducts, right? Okay, Mullerian inhibiting hormone. You should only do that if you have a Y chromosome, okay? With me? So I just disintegrated those. But then in order to complete the development of the male's primary sex characteristics, this is about 7 weeks post-implantation, you need for those gonads to decide, I'm a testicle, and start making testosterone. Just a shot right at that point will make that either clitoris or penis decide to become a penis. Either ovaries or testes, now I'm testes, I've decided. Continue the development of the male primary sex characteristics. So basically, the deal is if you don't do anything, you're probably going to develop as a female. If you want to develop as a male, you need to hit 2 switches in order at exactly the right point. So in humans, the default anatomical sex is female. Okay? It's not true in all animals. Okay, so that's MIH or MIS, Mullerian inhibiting hormone, only produced in a male during embryonic development. But what if part of this works and the other part doesn't? Then you can end up with one disorder, which is really an interesting story. And this disorder is called androgen insensitivity syndrome. You with me? Okay. And what happens in this disorder is you have this person, it's an XY zygote, that goes through this process, and MIH works just fine, MIH or MIS. So you get degeneration of anything that could become fallopian tubes in a uterus goes away. We all started out with a blind vagina, everybody did, right? You all used to have a vagina. Some of us still do. So they have a blind vagina, no uterus, no fallopian tubes. But the external anatomy, unless you tell it to make a penis, it's just going to make the typical labia majora, labia minora, the vulva of a female. That's the default, okay? So what happens in these people is they are insensitive to testosterone because they have a genetic disorder in which their androgen receptors just don't work. You with me? Okay, so they're XY, yeah? Okay, and they don't have any internal ductwork of a female. Externally, they look, the internal ductwork of a female. Externally, they look female, okay? And then they're gonna be born and you're gonna name them Susie, whatever, right? And then they're gonna grow up and then they're gonna hit puberty. But obviously, they're never going to menstruate, right? Because they don't have a uterus, right? But they are going to produce high levels of testosterone, but they're not going to respond to it. And if you produce it and don't respond to it, you're going to convert it into estrogens, which you can respond to, okay? And so they end up, adult people end up with a female anatomy. These are women with testicular feminization. And just to make sure that we have a physiological basis, androgen insensitivity or testicular feminization, in this family, all four of them actually had it. So this is a situation in which, although people get very uncomfortable talking about this, this is a physiological situation in which this person is transgender. Yes? Because their chromosomal sex and their anatomical sex do not agree with one another. Does that make sense? Okay. And interestingly, the vast majority of these women identify as female, above 90%, which suggests but does not solve the issue of what is it that mentally makes you male or female. This suggests that it perhaps is not just the presence of testosterone, but the response to testosterone on the brain, right? Does that make sense? Okay, so this is a situation that to me tells me that if there is one situation that allows me to understand how a transgender situation could occur, there are probably many others. And the reason I take the time to teach this is because if education doesn't teach you compassion, then it's literally doing nothing, right? Especially if you're going into healthcare, right? So this is just one situation. Go ahead.
So how do they find out that you
They
have-
usually find out at puberty when the girl does not menstruate. And so they take you in, and your OBGYN can very quickly figure out that you don't have a uterus. And usually the vagina is actually kind of short, right? So during the exam, you can usually figure out that they don't have a uterus. Does that make sense? So there's it's blind vagina, no uterus at the end, feeling around. And then eventually, by the way, they have to get their gonads removed because the undifferentiated gonads have a really high incidence of cancer. And then they have to replace estrogen for the rest of their
Do they
lives.
end up with like prostate and stuff too?
No, because that's all developed based on testosterone. So most of there's variation in this depending on when it's broken. Go ahead, Lori.
So their sex characteristics, their secondary sex characteristics, is there ever an issue, and I may be confusing things here, where you're not sure if there's a penis or a vagina, like if it's a micropenis or a large vagina?
It is. This is not the most common situation to develop intersex characteristics, but it does happen sometimes in these people. Most of the time, though, they're relatively typically anatomically female externally.
So then it's not a parental decision, like we're gonna,
It has
that
been.
micropenis is gonna be a clit or that clit's gonna be a micropenis.
Right,
Or,
exactly.
sorry.
It does happen, but not as often with this particular disorder as it does with others.
Okay.
This one is usually externally female. Go ahead.
Do their voices change?
No, that's all response to testosterone. It's all response to testosterone. Interesting, right? Go ahead.
So the only real effect that they can't have like children?
They can't have children. They have to have their gonads removed, and then they have to supplement estrogen for the rest of their lives. Before they knew more about it, they used to call it testicular feminization, but you don't want to diagnose a 14-year-old girl with something with the word testicle in it. Not if you want her to not commit suicide, right?
True.
Right? So it's androgen insensitivity. And it gets required genetic counseling now when they actually get the diagnosis. So, yeah, required genetic counseling. But it's an interesting one. They're usually relatively tall. They hit puberty a little later because males hit puberty a little later and just a little more dramatically, right? Like big bursts of hormones. And they usually have relatively large breasts. They kind of look like supermodels. Go ahead.
You said that they need estrogen for the rest of their life,
They have to remove their gonads.
so they're not still producing that testosterone
Yes.
to
Mhm.
not respond to
Yes,
puberty.
exactly.
Okay.
Just because the gonads have high incidence of cancer before they differentiate. So that one's kind of an interesting one, right? I mean, if it doesn't make you curious, I don't know what the hell's wrong with you. Okay, and there's another disorder, but we'll talk about this one more later. Precocial puberty is when you hit puberty way too young, like 4. And that can be because of, for instance, a tumor here, or here, or here, right? It's a problem. And we'll talk about it again when we get to the adrenal cortex, because you can also have an adrenal cortex tumor that causes that to occur. Okay, but last thing is, since we just did this, let's do the same thing for females. Okay, let's do the ovaries, right? The female gonads. You guys probably know, but I'm going to just repeat it for you. The ovaries and the testes are the same embryological structure. They're homologous structures, right? And so, not surprisingly, this is going to be almost exactly the same story when we're talking about the ovaries. And the ovaries are, of course, going to produce estrogens, which is a group. Estrogens are going to be responsible for female secondary sex characteristics, breast development, the start of menstruation and ovulation, changes in body fat deposition, axillary, pubic hair, all that kind of stuff, right? And growth, right? But just not as much as testosterone, right? But interestingly, estrogens are not at all responsible for sex drive. I would, again, like to speak to the management. So it's androgens in both sexes that are responsible for sex drive. Estrogen can get you knocked up, but you didn't even have to enjoy it. Okay, so here's the estrogen story. Starts the same. Starts with the hypothalamus. And this is at puberty. Will make you release GnRH. We know what that stands for, right? GnRH will go the same damn place it always goes. Good. And then the anterior pituitary will release luteinizing hormone. Luteinizing hormone will go to certain cells within the ovaries, not the same ones that do oogenesis. And you will produce estrogens in response. There are, again, a few different kinds of estrogens. And some of them have different affinities for the receptors than others. Where are you, estrogens? There you are. So these are the estrogens collectively. Okay. And then what do you think the feedback is? It's the same. Yeah, it feeds all the way back. Hypothalamus, because it's lipid soluble, and anterior pituitary. Good. Okay. This is far more cyclical. Yes, we all know that. Than it is in males on our 28-ish day cycle, right? Their cycle isn't a really dependable length, interestingly. It is cyclical, but it's not a really super dependable length. And then in addition, the anterior pituitary will, of course, secrete FSH, which will go to the ovaries, different cells in the ovaries. And the ovaries will respond by doing oogenesis. But the egg definitely doesn't swim because it doesn't even have a little outboard motor. So how do you know when you just ovulated? Inhibin. Yeah? And inhibin will feed back to the anterior pituitary. But of course, which sex is going to release inhibin more frequently? Males, yes? You're going to release inhibins once a cycle. Do you have a question?
Yeah, so I know, like, if you're trying to get like ovulation tests for your LH levels, why does it do that instead of testing?
Let's look. Same kind of thing that you saw here. Your LH level will determine your estrogens. You need estrogens to stimulate oogenesis in combination with FSH, right? So same thing with males. If you don't have any testosterone, androgens, you won't do spermatogenesis. In females, if you don't have adequate levels of estrogens, you won't do oogenesis. That makes sense? Yeah? All of these estrogens, FYI, and we'll get into it in more detail next time, but these estrogens are actually just converted androgens. So one of the big differences in males and females is that females just have more of the enzymes for conversion of androgens to estrogens, but we both have androgens and estrogens. Does that make sense? Okay, so this is the story in women, which is pretty, I mean, if you got one, you got the other one, right? They're the same story, really. Necessary for the female reproductive cycle, including oogenesis. Let's briefly talk about progesterone. Progesterone is an interesting one. It's produced primarily during a certain portion of a woman's cycle, and it's actually a little positive feedback loop in which a certain level of estrogen will make you actually release progesterone, and the progesterone will make you release more progesterone until your progesterone spikes. Progesterone is produced from the ovaries to talk to the uterus. And you can always remember what it does if you just think that it's progestation. Yes? It is progestation. So as a woman gets to the point of her cycle right before she ovulates, her progesterone levels should be rising. Yes? And what does the progesterone tell your uterus to do? Yeah, get baby friendly, get a big thick endometrium in case fertilization and implantation occurs, yes? So get a big thick endometrium and then just holding pattern, hold, right? And ovulation will occur after that has occurred, and then you give yourself a few days, a window, sometimes a week, in which fertilization could theoretically occur and implantation could theoretically occur. And then after you're out of the window, your body goes, oh, not this cycle, and your progesterone drops, right? And when your progesterone drops, what occurs? Menstruation, right? Your menstrual period occurs. And then you start the same damn thing the next month, right? So that's how progesterone occurs. Progesterone is really just the ovaries telling the uterus what to do. Does that make sense?
So the progesterone is assisting the ovaries telling the uterus what to do?
No, the progesterone is how the ovaries talk to the uterus.
Okay, so it's just, so it's like kind of like a, so to speak, like a mail, like a letter or whatever, like the ovaries.
Yeah, it's telling them what to do.
Okay.
And so, since we have somebody in the class who's pregnant, what happens to your progesterone level during healthy pregnancy the whole time? What should it do? It should stay where? It should stay high, yeah. Your progesterone level should stay high during your whole pregnancy because it's pro-gestation. It is pro-pregnancy, yes? Some women who have trouble with fertility issues, they sometimes get progesterone treatments to help them to maintain the pregnancy during the first portion, right? Because if your progesterone drops, then you'll slough off the lining of the uterus and you can actually lose that pregnancy. Does that make sense? Okay, so that's how progesterone actually works. And then one other little hormone related to the ovaries is relaxin, and relaxin is kind of a cool hormone. It's only produced during childbirth. Anybody in here moms but me? Yeah. 1, 2, just 2, 3. Oh, why are you not saying?
I'm not.
Okay, so I didn't feel this, but some of my friends have, because I had a planned C-section because I had a heart problem, so I didn't do labor. But full-term babies will cause a little loop that will cause your ovaries to release a hormone called relaxin. And what relaxin does is it courses through your body and it relaxes the connective tissue so that this will let go, right? So that your pubic symphysis will actually have a little give to it, and your os coxae can let go, and your sacrum can actually sort of move back a little bit. But interestingly, one of the things that happens is that since it goes into the bloodstream, it kind of affects everywhere, and it kind of makes you feel super floppy. My best friend who told me that she felt that, she said, like, it felt like if I threw a ball, my arm would go with it. Like Elastic Man, just like, so it sounds kind of pleasant to me. Do any of you guys feel it at all? Right? If you're super doped up, you won't feel it. If you've already have an epidural, you might not notice it. But
Where you like can't walk after?
yeah, well, your ligaments and tendons and joints do not actually tighten up for a little while afterwards.
I had natural birth, but I couldn't walk after.
Oh, that's probably what it has to do with, is relaxin. It has to clear out of your system a little bit. So anyway, that's what?
Clear out.
Depends on how much you release. Some people, it's a matter of hours, and some people it's a couple days before it actually all clears out.
Then, like, if they have to induce you.
Not usually, because it's actually released by the whole parturition process that's initiated by the baby. So I didn't have it at all, right? So, and my baby was 3 weeks early anyway, so it's like nowhere near ready to come. So anyway, what's the feedback mechanism for estrogens? Hormonal, right? What's the feedback mechanism for oogenesis? Hormonal as well, right? Inhibin feeds back. Last little tidbit as we're about to leave. If you want something to argue with your family about over Thanksgiving, here's RU486. RU486, depending on your political leaning, you might call the morning after pill. You might call it an abortion drug. What it does is it blocks progesterone receptors. Progesterone antagonist. So, if someone, for instance, had a condom break or had a sexual assault, you can, even in Utah now, you didn't used to be able to, as part of the treatment afterward or even at the pharmacy, you can get the morning after pill, and what it will do is block progesterone receptors, so that if a fertilization occurred, right, an implantation can't occur because it sloughs off the lining of the uterus. So from a physiological perspective, it is a pregnancy preventer because pregnancy is implantation, right? From a political perspective, I don't care what you say, but pregnancy is implantation, not fertilization. Only about 50% of fertilization events implant anyway. So what you're doing in this situation is saying it might have had a fertilization, let's make sure there's no implantation, which is actually, by the way, what IUDs do as well. So even though this one is really, really controversial a lot of places, IUDs are not very controversial, but especially the copper IUDs. Okay, I will see you guys on Tuesday. There is a quiz up. It's long, not super hard. It's just getting you started thinking about endocrine system, but it's a lot of questions. Collaborate.
20 questions.
20 questions.